Dr. Madani, thank you so much for coming and giving us grand rounds and letting us know about the management of CTEPH, chronic thromboembolic pulmonary hypertension. Certainly, in the years that I've been practicing in the past 20 or so years, the management and understanding of this condition has improved and come in such a long way, leaps and bounds. But as you have so eloquently shown us, there's still yet so much work to do. And I think we are sort of on the tip of the iceberg, if you will. Now there's more management modalities that is coming in our way, from medical to of course, more refinement of the surgical techniques and of course, non-surgical interventions. But I think the recognition and awareness from the community of what CTEPH is and the progression thereof, I think that also is a big aspect of the work ahead of us. So I just wanted to see what your thoughts were as where we are compared to where you initially stepped into this field.
Well, first of all, thank you, Myung, for having me here, and it's been an absolute pleasure and an honor for me to be invited here and share with you our results and experience in San Diego. I agree with you 100%. I mean, the field has grown significantly. I've been involved in it now since 1999, 2000, but in the last 15 years, things have changed dramatically. And it's not just so much the surgical skills or surgical techniques. That actually has not changed a whole lot, but it's really diagnostic modalities, the recognition of the disease, as well as other forms of management of these patients. The challenge has always been recognizing the disease, and as you very well know, we feel that it's significantly underdiagnosed, and we think that there is a significant prevalence and the incidence of disease is much higher than we recognize. And we're probably just addressing maybe 10–20% at the most of the patient population who have this disease in the country. But I mean, in the last, I would say, probably 5–6 years, there's been an interest from physicians as well as from the pharmaceuticals, who have been really great partners to increase awareness. And I feel that over the last several years, we do see more patients, and certainly we get referred a lot more patients than we used to. And it's not because all of a sudden all these patients are getting, the disease. It's because they're not being recognized. We still have a lot of work to do. That's a challenge. To really get the word out and educate the frontline physicians to think about this disease when patients present with shortness of breath and no other really explanation, to think about this disease. Surgical techniques have improved to some degree, where we are becoming, as the results improve and as our hemodynamic outcomes and mortality improve, we're becoming more aggressive in addressing patients that we would have turned down even a few years ago, patients with distal disease, patients who are higher risk. So, and also some refinement of the surgical instruments have allowed us to get farther into the distal vessels. And we have recognized over the years that really the best outcomes really come to people who have a true and very thorough endarterectomy. It doesn't matter how long they're on bypass, it doesn't matter how long it takes, as long as it's done according to certain principles. The most important factor is to make sure there's a complete endarterectomy.
I mean, certainly, I think over, when I think about the patients that I've seen and the responses they've had to a well-done endarterectomy, it is miraculous, the change before and after. I mean, you have people that go in with needing high flows of oxygen, on pumps, all kinds of medications for their pulmonary hypertension, and yet due to the obstruction, of course, these therapies really do not have the benefit and the efficacy that we know that they can have in the absence of the obstruction. But once they undergo the surgery, I mean, they come home minus the oxygen and the medications, and with their heart and lung functions restored. It's a miracle that, you know, even that you don't see even with a transplant or any other modern day techniques that we have. And to me, being able to afford a patient that kind of chance is, one, something that we cannot miss. And two, like you said so well this morning, you know, a diagnosis can only be made if you think of it and you search for it. And I think that applies to CTEPH more than any other condition that I can think of. It's not something that you kind of stumble on by mistake. So if with that in mind, and there's still the debate about the VQ and the CT, you know, that's probably still an ongoing active controversy. And can you just give us a few opinion about where we are with the new technology coming out on the CAT scan, and of course VQ being the tried and true?
Yeah, I think I don't know if there's so much controversy about VQ scan. I think the expert opinion today in 2016 is VQ scan as a test. And I agree with you 100%. CTs are getting better, and we're able to recognize chronic thromboembolic disease much better than we were a few years ago, especially with the high resolution, 320 slice CT scans, and things are improving, every day, and it may change at some point. But the bottom line is that the VQ scan is a relatively straightforward test. If the VQ scan is normal, you've pretty much ruled out the disease, that the patient doesn't have obstruction, doesn't have chronic thromboembolic disease and obstruction as related to that. Of course, if they have obstruction and VQ scan is abnormal, you have to do further work to make sure that it is CTEPH. But I think at this point in 2016, we still rely on CT. I mean, we still rely on VQ scan as the diagnostic test, and it's amazing that, and I'm sure you're familiar with the Reveal registry showing that all these PH doctors, I don't remember exactly, but it was less than 50%, 40-some% that get VQ scan, right?
Absolutely.
So all these PH patients, and over 50% of them have not really been ruled out adequately by not having CTEPH. Right?
And I can speak from my own experience that when I get a referral patient and they come in with an outside CAT scan with an angio that shows no acute pulmonary embolism, and now when you do a VQ, you see that there are areas that are highly suspicious for chronic changes that you cannot pick up or was not picked up by a CAT scan.
Yeah, it's very different. The chronic diseases, CT is a great test for acute PE.
Oh yes, absolutely.
And it has very high sensitivity, and but the sensitivity of CT, I mean, there's studies that shown, it's about 50-60% for chronic thromboembolic disease, and the sensitivity of a VQ scan is well over 90-95%.
I think this is something that really is a lesson for all of us, is regardless of what the CAT scan may or may not show, a VQ scan, if that is in your differential, you need to get a VQ scan.
Yeah, and it's quite helpful for many reasons. I mean, not only you ruling in or ruling out the diagnosis, it also is important to have as a baseline.
Right.
And then you have one, if the patient does have a procedure done, surgery, or you could repeat it to see how that's changed, and have that as baseline for the future. If the patient comes back for further symptoms and the VQ scan looks the same, then you know that it's progression of small vessel disease or other factors, and it's not new thromboembolic disease. And CT, I love CTs. I mean, we get it all the time for all kinds of studies. But for this particular disease, it's still not there, and we don't know. The CT findings after pulmonary endarterectomy, and then years after pulmonary endarterectomy, how the vessels change and how they remodel. So I think we still have a lot to learn. But today, as of now, VQ scan is still the test of choice.
Now, just shifting gears a little bit. Now, you've been at UCSD since 1999.
Yes.
26 years.
16 years, actually.
Oh, 16 years. My math is off. My
right.
apologies. So if you track back those years, I mean, certainly your center is regarded as the best center for the management of CTEPH and in the world. And I know that you get patient referrals from all over the globe. If you think back, can you share with us maybe one or two aspects, lessons that you've learned, maybe things that you have experienced that have changed the way you practice this condition?
Absolutely. I've been very fortunate, Myung, to have a stellar group of people that I work with, and I came into the program when it was already very well established by Stuart Jameson and Bill O.J. and Peter Fidulo, sort of the pioneers coming after Ken Moser. So a lot of the lessons had already been learned, and I was just lucky enough to be at the right place at the right time. And obviously credit should be given where it's due, and to the pioneers who started the program. Over the last 16 years, of course, I mean, one thing that's for sure is this is not a disease that one individual, two individuals, or three individuals can tackle and have a successful outcome. This is true teamwork.
Yes.
And it comes at every level. I mentioned during grand rounds, I mean, it's not just the surgeon, it's the anesthesiologist, but you were at our center, it's the perfusionist, it's the nurses, it's the respiratory therapist, it's the physiotherapist, pharmacists. I mean, I can go on that are geared towards this disease, and having that collaboration and having that mindset is, of course, part of the challenge. We've become better at over the years recognizing the disease, and as a result, the incidence of operating on non-CTEPH patients have gone down. So, and that just comes with experience. And of course, imaging and better resolution has also helped us. The other thing, as I mentioned earlier, is really for us to take the time and do a complete endarterectomy. So a lot of times, the disease may be distal, to the point that I open the vessel and say, wow, there's not much here. But I was still knowing that the VQ scan is abnormal.
Abnormal, right.
Knowing that there were some clots distally that we saw in the angiogram. I just I start the endarterectomy where I can in the more proximal lobar segmental vessels. It's a little harder because the vessel is normal, so you can't pull on it because things sort of break off. And then carry that on until you get to those distal vessels. And that's something that we learned over the last probably 4 or 5 years. Yeah. We also learned that in order to get to those distal vessels, you needed better instruments, smaller, finer instruments, and because you're so far, you don't want the tips to sort of cross and scissor. So we modified the instruments, and we actually have called a few patients back that we had turned down in the past.
Okay.
And said, we think you're a candidate. We didn't think we could get.
And that's progress.
Yeah, and that's exactly.
Yeah. So in the same light as your surgical understanding and refinement progresses, would you now recommend or offer the surgery to patients who have the thrombus, but who hasn't really developed pulmonary hypertension yet?
Yes, so that's a very good question, because the reason we do the surgery, the reason we offer the treatment are, of course, multifold. The most obvious one is to get them better, get the pH better, and get their symptoms better.
Yeah.
But the other reason is sort of prophylactic, to make sure they don't get worse. And there are two factors that come into that, especially if it's a younger patient. By having thromboembolic disease, you could potentially affect the portion of the lung that has the clot or the thromboembolic disease, and potentially over the years that portion can become scarred. And even when you go in and do endarterectomy, you may not get as much function in that area if they don't have adequate collateralization. Now that's not true for everybody, because people do develop good bronchial collaterals, but occasionally we do have patients who just get some infarcts and get scarring. So of course you don't want that to happen. Second is you don't want small vessel changes to happen. And if you could remove the clots before that's progressed, then that's another prophylactic measure. We would offer this operation as long as patient has thromboembolic disease and they're symptomatic, for reasons that I mentioned, but also to minimize the dead space ventilation essentially, and have a good ventilation and perfusion match, which they don't have. We measure the pulmonary pressures at rest. We try to exercise them, but really we don't really have an idea what they are when the patient is active and walking around. So as long as they're symptomatic and they have thromboembolic disease, even if they don't have pulmonary hypertension, we would offer surgery. Of course, if they have a little clots here and there, we don't. But if they have significant blockage, we would offer them surgery, even if they don't have pH.
Now, with all the innovations that we've been discussing, what do you project, say, next 10 years, as the approach and how much we can provide for patients that have chronic thromboembolic pulmonary hypertension?
I think over the next 10 years, the recognition will be much better, as we have seen over the last few years. I think there'll be many more centers around the world that do a very good job with surgery. And I think the disease will be managed in a multi-disciplinary, multi-modality fashion, meaning that I think patients will potentially have a selection of medical therapy, balloon pulmonary angioplasty, and surgery to go with. Surgery being the most successful and reserved potentially for complete obstructions, to medical therapy and balloon angioplasty for more distal disease, areas where you see narrowing and webs. So I think there is certainly a role for both of those treatments, and I think over the next 10 years we're going to see an increase in all those, so increase in volume in every aspect, but a good portion of patients where we didn't have any option for, patients with high PVRs and distal segmental, subsegmental disease here and there, are going to be treated now with balloon angioplasty. Now, sorry, I was going to say, I mean, ideally, I would think that potentially you could do that in a hybrid approach, where you
that's what I was going to ask.
Yeah, I mean, I've thought about it often, to potentially do the endarterectomy and whatever is not there, to address it right there as a hybrid approach in a hybrid room. But that's, at this point, it's just a thought and idea. We haven't really explored it more than that.
But it certainly does have really exciting applicability when you think about the areas that you can target.
Yes.
And with different operators working on a patient side by side.
Exactly.
In order to get a more complete resolution of the clot burden.
Exactly. Yeah.
I mean, I think that affords an incredible future. So this is as a last imparting thought. I mean, you certainly have had shaped so many people in all disciplines, and medical, surgical, and all practitioners in learning about this condition, what can potentially be done, and of course, and your input in helping centers, pop up, if you will. Not only in the U.S. but in the world. I was reading in your CV that you have helped to build a center in Beijing, China, and they have honored you with an honorary degree. I mean, I think bringing us an incredible treatment of this magnitude to a area of the world that I know is a totally foreign, I think that is an incredible legacy and achievement. So, I mean, I thank you for all of your efforts.
Yeah, it's an absolute pleasure, and again, as I mentioned earlier, for me, it's a great learning opportunity. When I go, and it's somewhat stressful. It's somewhat nerve-wracking. You go.
I can only
you're
imagine.
in a foreign land. The OR staff doesn't speak your language. You don't know what their capabilities are, but we've been very successful in helping actually 2 centers in Beijing, and now a 3rd one coming over the next year or so, who are really interested in disease. And for me, seeing that these patients, many of them are very young, are now getting treated and having another chance at life is very gratifying. And like I said, I learn a lot. I learn a lot every one of these trips, and from the surgeons, from the physicians, from the people. So it's a part of my job that is extremely gratifying for me, and I love doing it. So anytime I go and travel to some remote area of the world and help them start a program, and then see how they progress and become self-sufficient, it's very gratifying.
So what kind of words of advice would you, career advice, life advice, for surgeons, physicians that are interested in exploring this area of medicine? And what would you tell them, what the future may be, and some enduring advice that can help them achieve those goals?
I think it's like anything else. It comes with a passion, and I think the passion has to be there.
Yes, can agree more.
And I think if the joy and passion is there, everything else comes second. It's a challenging field. We're still learning a lot from it, so there'd be disappointing results. And I think if I had a comment or a recommendation, would be that if you're really not passionate about this, then you shouldn't really pursue it. It shouldn't be a side job, essentially.
Yes.
You need to be devoted to build a program, to enjoy the operation. These are for me, they're extremely enjoyable. I mean, I do 3-4 of these every single week, and I never get tired of it, because every one I enjoy. It's an operation that I truly enjoy. And if you don't have that, then I think it's going to be challenging to build a program. The other aspect of this is to really be cardiac surgeons. All of us tend to have big egos, and I think this is one of those areas that you have to really put the ego aside and think about the patient and think about their outcome. And if I'm just throwing a number. If a surgeon is doing, just a handful, 4 or 5 of these a year, I think the patient is better served to go to another center that does at least a few every month,
right?
At the minimum. So I think that's the challenge. I think as surgeons, we find it very hard to say, oh, you know what, I don't do that. You should go somewhere else, because you don't want to admit that.
Do it all, yeah.
We do everything, and places that unfortunately have started and have not been successful, I think that's been part of the challenge, because they've taken on cases that they shouldn't have done,
Too difficult,
and then the outcomes are not great, and you start a program and you have a couple of bad outcomes and the whole program shuts down. And we've seen that happen. So my advice is for a starting program, to choose the patients carefully, to make sure the volume is going to be there,
yes,
and to have a passion and about the disease and about surgery, and not and don't have a big ego that's going to get hurt easily. But that's going to be hard to find. So,
well, Dr. Madani, thank you so much
my
for
pleasure.
your time and for sharing with us your experience. Your passion is something that we all have benefited from, and something that is so extraordinary that we really thank you for your pursuit and for your dedication.
It's an absolute pleasure. Thank you for having me.
Thank you for visiting us.
Thank you.